Welcome everyone to today's webinar. I think it's going to be an exciting topic. And before we start, I'm going to introduce our speaker. Dr. Josh Sisler is an assistant professor in the Psychiatric Research Institute and conducts functional neuroimaging research in the Brain Imaging Research Center. He received a doctorate in clinical psychology from the University of Arkansas, Fayetteville in 2010. His research at that time focused on emotional and cognitive mechanisms that mediate anxiety disorders. He completed a clinical internship at the Medical University of South Carolina through the National Crime Victim Research and Treatment Center, where his research focused on understanding risk factors for psychopathology following trauma, with a particular focus on assaultive events. He then completed a postdoctoral fellowship in the Brain Imaging Research Center here at UAMS, where he received training in fMRI methodology and advanced computational approaches to imaging analysis. His research focuses have on identifying disruptions at the neural network level of analysis that mediate risk for mental health disorders following assaultive violence exposure and understanding how treatment modifies functioning within these neural networks. His clinical expertise is in adult anxiety disorders with a particular emphasis on PTSD. I'm going to go over a couple of housekeeping items, and then I'll turn the webinar over to our presenter, Dr. Sisler. So just a few housekeeping items. If you'd like to ask a question during the presentation, please use the question feature, which is found on the right side of your screen. And if you'd like to earn 1 CU, just be sure to stick around to the very end. We'll have a code that's given out, and you'll need to email it to me. If you're watching in a group today, everyone will need to email me individually. And if you're watching this online, when we later post this to our YouTube channel, we only give out CUs for attending live webinar events. So I'm going to go ahead and turn it over to our presenter and let him introduce his topic today.
Thank you, Chad. I appreciate the introduction and the invitation to talk about this research. As you saw from the title, what I'm going to be talking about today is a recent study that we completed here. And it was a cool study from my perspective because it was a really good collaboration between our Brain Imaging Research Center and with ARBEST. And a lot of you have probably heard about this study before, or at least heard me trying to recruit adolescents for it. So it's all local Arkansan girls were participants, and we got actually most of the participants through referrals from ARBEST clinicians. So it's nice to be able to kind of talk about the study so the ARBEST clinicians who help with it can see what we're learning from it. So I'm going to talk a little bit about what the purpose of the study was, what we did in the study, and what the study is telling us about how we can make TF-CBT even better. So as you all know, trauma-focused cognitive behavioral therapy is our gold standard treatment for youth who have traumatic stress-related symptoms. So that might be PTSD-related symptoms, or it might be depression or behavior problems, but it's related to a trauma, so it's a traumatic stress-related symptoms. But even though TF-CBT is the best treatment that we have, it's not perfect, right? So we don't get 100% symptom reduction in every child who undergoes TF-CBT. So as an example of that, if you've been through the ARBEST training, you're probably familiar with Tony Manarino, Judy Cohen. So they're the group that developed TF-CBT, and these are results from one of their recent clinical trials. This was administering TF-CBT to children with PTSD-related symptoms in a community setting. And I put a box over here. This is the average amount of symptom reduction from pre to post treatment. So if you're familiar with the DSM-4 criteria, which have changed a little bit now, it's PTSD re-experiencing symptoms. You need one of those. 3 avoidance symptoms, and 2 hyperarousal symptoms to have a diagnosis of PTSD. So if you look at the change from pre to post treatment, you can see that on average, most of the children were pretty close to meeting criteria for PTSD even after treatment. And this is, like I said, this is treatment delivered by the people who develop TF-CBT. So they really know what they're doing. They probably have the best expertise in it. Nonetheless, in one of their recent trials, a lot of children are still having significant PTSD symptoms after TF-CBT. So the point is, can we make TF-CBT better? We know it works better than nothing, and we know that many children experience a very good response to it, but we want to be able to make it perfect. We want to be able to make it as 100% as we can. So with this kind of study that we're doing, our overall goals are to understand or to test if we can identify, say, some marker before treatment that lets us know, is this kid likely to be a really good responder, or is this kid someone who's maybe not going to respond as well? And if we have that information right from the get-go, maybe that'll inform what type of treatment we can do, or maybe it'll inform how we could tweak TF-CBT to be best tailored for that individual child. And a related goal is, can we identify through what mechanisms or through what specific processes is TF-CBT helping children improve their symptoms? And if we can identify whatever that process is, then maybe we can tweak TF-CBT to more potently engage that process. Okay, so just kind of an overview of what we did. We recruited adolescent girls who had a current diagnosis of PTSD, and the PTSD was related to either physical or sexual assault. This is directly experienced physical or sexual assault. After we had identified the child and confirmed the diagnosis and the trauma history, they received 12 sessions of manualized trauma-focused cognitive behavioral therapy. And this was delivered by people you're probably familiar with, Drs. Karen Vanderzee, Joy Pemberton, and supervised by Ben Siegel. So they got really good therapy. It was manualized in the sense that we had to provide it in approximately 12 sessions. So when you're doing it in the community, you can move through the modules kind of at the pace of the child. In order to increase the comparability across children in this study, we wanted everyone to get the exact same dose of the treatment. So we manualized it to 12 sessions. So sometimes the children had to move through the module a little more quickly than you would in a community-based setting. But nonetheless, we tried to follow the standard practice modules as best as we can. So if you've been to the RBEST training, the treatment they got in the study is essentially the exact same treatment that you learn to do at that conference. Before and after treatment, we assessed clinical symptoms, and before and after treatment, we did a brain scan. So we were doing functional magnetic resonance imaging, which allows us not just to see what the structure of the brain is, but to get to see how the brain becomes active or engages when the child's doing different tasks. So we had them doing cognitive tasks while they're in the scanner. This is an image of the enrollment flow through the study. So you can see that we assessed 53 for eligibility. Some of them were excluded for various reasons here. We consented 39 to begin the study. Of those, 34 actually began TF-CBT, so they got at least one session. And of those 34 who got at least one session, 25 completed all sessions. So I'm going to be focusing on these 25 who received all modules. And like I said earlier, they may have finished a little early. They may have finished in 10 or 11 sessions, but nobody got more than 12 sessions. While they were in the scanner, we had them do two different tasks. So we could probe what their brain is doing when they're doing these two different cognitive tasks. So one task that we had them do in the scanner is what I'm going to be referring to as an emotion processing task. They see images of either a fearful expression or of a neutral expression, and they kind of appear on the screen one after another, and the child's job during the task is to press a button indicating if the picture is of a man or a woman. So they're not being told to pay attention to the emotional content of the face. So we are measuring implicit emotion processing, right? So they're not trying to look at the emotion, they're just incidentally looking at the emotion while they're doing something else. So this is kind of the brain's automatic reaction to emotional stimuli. That's what we're looking at in this task. And in the other task that we did, this is an emotion regulation task. It's called cognitive reappraisal. What they're shown in this task is they've seen an instruction come up on the screen, and the instruction will either say, notice your feeling, or it'll say, think positive. And then, after they get the instruction, an image will come up. And the image will either be a neutral image, or it'll be a negative image, such as this one. And if the instruction is to notice your feeling, they just are supposed to notice how they feel when they look at the picture, and that's it. But if they get the instruction to think positive, then when they see this negative image, they're supposed to think about it in a way that makes them feel better. So for example, they might say to themselves, the building wasn't safe, so they're taking it down to build a safer one. So that reappraises this image from negative interpretation. Say, negative interpretation might be that people are in the building and they're dying, to a positive interpretation where this building being taken down is actually a good thing. And this is kind of a complicated task. It's not easy to reappraise, so we kind of train them before the task so they get some practice in doing it and they know what they're trying to do. And you're probably familiar in the cognitive coping skills building part of TF-CBT, you're also teaching them to do something very similar. So this task maps on pretty well to teaching the child to do cognitive restructuring. Okay, so this is some information about the participants that we had. So you can see the average age was a little under 14. The average IQ was a little below 100. Half of the children were African American. This was a heavily traumatized sample. So this is the total number of categories of assaults that they were exposed to on average. So for example, a physical abuse from a caregiver would be one category. Physical assault from a non-caregiver would be another category, but you could have multiple experiences within those two categories, but it would only count as two on this kind of a measure. So when we're looking at children who on average have 6 categories of assaults, keep in mind that within those categories, they probably had multiple re-victimizations. So this is a very traumatized sample. Like I said, they experienced, to be in the study, it had to be direct physical assault or sexual assault. In addition to that, many of them witnessed violence as well. Many of them were taking a concurrent psychotropic medication. And this is some information about how their clinical symptoms change from before to after the 12 sessions of TF-CBT. So all of them started with the diagnosis of PTSD. After treatment, only 35% had met criteria for PTSD, so that's good. Average number of comorbid diagnoses decreased pre to post treatment. And you all are probably familiar with the UCLA PTSD index. So their scores on average dropped by about 18 points. So these outcomes are good, and the clinicians who were helping actually do the therapy in the study, they know that these outcomes are actually really good. They're slightly better than you typically see on average in the clinical trials that get published. So on average, the girls did really well in therapy. But like I mentioned before, there's a lot of individual differences in how well the girls respond in therapy. So this is a histogram just showing the distribution of symptom change. So on this axis here, we've got how much they change on the UCLA PTSD index. So for example, this girl dropped 50 points on the UCLA PTSD index, which is a huge drop. That's a huge symptom improvement. We had one girl do that, and then we had 3 girls who dropped by about 20 points, 6 girls who dropped by about 15, et cetera, et cetera. So you can see how to read this. So most girls, on average, probably dropped about 18 points in here, but we had a lot of girls who did better than that, and we had some girls who responded less well. So what we really want to do is we want to understand why is there this variability. can we identify a marker of who's going to be what I'm going to call a low responder? Can we identify maybe beforehand who's likely to be over here? Can we identify beforehand who is likely to be over here? And this, what I'm going to call high responders and low responders, is just based on a median split right here. So everyone, this is kind of a false dichotomy in the sense that it's a continuous score, but for the sake of ease, I'm just going to refer to everyone on this side of the line as a low responder, everyone over here is a high responder. Okay, so coming back to our first question of who is likely to be a good responder to TF-CBT, can we identify, say, some marker before treatment that lets us know who's going to be a good responder? So for comparison, what I'm showing here are just some readily available behavioral measures. So when you're working with someone in the clinic, these are things that you could, if you don't have access to already, you could probably easily get. So age, for example, verbal IQ, their assault history, if they're taking medication, number of comorbid diagnoses. And I have all this information plotted as a function of whether or not they were a high responder in blue or a low responder. And as you can see across all of these, the only behavioral measure or clinical measure that actually predicted who was going to be a high responder or low responder was the severity of PTSD symptoms at pre-treatment. So those people, those girls who had more severe PTSD symptoms before treatment, they were likely to respond better, which makes total intuitive sense. They have higher symptoms to begin with, so they have more symptoms that they could lose, right? So that makes total intuitive sense, and that's what you see in pretty much all clinical trials, that those with the most severe initial symptoms tend to be the ones who improve the most. But other than that, nothing else actually differentiated who was going to respond or not. So it didn't matter how old they were. And again, this is a constricted range, so it's just 11 to 17. Verbal IQ didn't predict who was going to do well. How severe their assault history was didn't matter. Severe depression symptoms didn't matter. Rule breaking and aggressive behavior, these are subscales for the child behavior checklist. So kind of getting at conduct disorder symptoms or oppositional behavior, and that didn't predict outcomes. The child's ability to regulate emotions wasn't a strong predictor. We had some measures of family and parenting behavior, so how cohesive that was. This was per the caregiver report. Didn't predict outcomes. The parental involvement didn't predict outcomes. Whether or not they were taking psychotropic medications didn't predict outcomes, and the number of comorbid diagnoses also did not predict clinical outcomes. So this, I think, kind of sets up doing the imaging analyses in the sense that there's not a lot of strong predictors of who's going to get better that's readily available to you in the clinic. What I'm going to use here is data from the emotion processing task. That's when they're looking at the fearful versus the neutral facial expressions. And we're going to characterize their brain activity at pre-treatment. And we're asking, how reactive their brain to emotional images before treatment, does that predict how much symptom reduction they're going to have after treatment? Okay, so what we're looking at in this slide are two brain regions. We've got the left amygdala, we've got the right amygdala extending up into the striatum. And what these two regions are doing, if you're familiar with the amygdala, is they help us process salient stimuli. So an example of a salient stimulus would be a fearful facial expression. A salient stimulus is anything that's relevant in our environment that we need to pay attention to. So it could be a loud noise, it could be a snake, it could be a spider, or it could be fearful expression. So our brains are kind of hardwired to detect those salient cues, and in this context, facial expressions. So these two regions, how active they were to fearful versus neutral images, did significantly discriminate who was going to be a high or low responder. So we got the same color scheme here. Blue are the girls who responded really well, and this kind of maroonish color are the girls who didn't respond as well. And what I have here are the stimuli that they were seen. So this is all types of fearful stimuli versus all types of neutral stimuli. So if we just focus right here, what we can see is that our girls who responded really, really well at pretreatment, there was a big difference in their amygdala reactivity to fearful versus neutral stimuli. So there's a big difference here for the right amygdala. There's a big difference here for the left amygdala. So their amygdala is more active to fear stimuli than it is to neutral stimuli. The girls who didn't respond as well to treatment didn't show that differentiation. So their amygdalas were active to fear. Their amygdala was active to the neutral phases. And that's also true for the right amygdala and the left amygdala. So again, the girls who didn't respond as well demonstrated an amygdala response to both the fear stimulus and the neutral stimulus. So this is kind of getting at the idea of safety discrimination. And here I have just the images so you can see the difference of the response to the fear stimulus and the response to the neutral stimulus. So their amygdala is activating to both, they're not differentiating. And the degree of amygdala discrimination between the threat signal and the safety signal, it predicted PTSD symptom reductions, but it also predicted improvements in emotion regulation. So those girls who had the biggest difference between fear and neutral stimuli pretreatment, those are the girls who showed the greatest improvements in these two different measures of how well the children could regulate emotions. So that's just showing that the relationship with the brain wasn't just for PTSD symptoms, it was also for another indicator of clinical functioning, right? So you don't just want the people you're working with to have less symptoms, you also generally want them to be better equipped to handle strong emotions in general. So like I mentioned, we found that adolescent girls whose brains, specifically their amygdalas, better differentiated from danger and safety signals were the ones that were most likely to respond to TF-CBT. And I'll kind of come back to the implications of that when I get into the overall discussion. So the second thing that we wanted to look at are what are the mechanisms of TF-CBT? How does TF-CBT produce symptom change? So to kind of draw an analogy, if you take penicillin for fever, generally speaking, penicillin helps reduce the fever, but it doesn't do that directly. Penicillin doesn't directly work on the fever. Instead, you would take penicillin if you have a fever resulting from an infection. And what penicillin is actually doing is targeting those bacteria. Getting rid of those bacteria is actually causing the fever reduction. So the idea is that there's an intermediate mechanism. So we want to do the same thing with TF-CBT. So we know that TF-CBT tends to produce clinical change or reductions in PTSD symptoms. We want to know how that happens. So through what mechanism is TF-CBT working that produces the symptom change? That's our goal here. So one thing that we looked at, one behavioral measure that we looked at, was emotion regulation. So that's what the DIRS is. It's the difficulty of emotion regulation scale, with higher scores being worse. So what we looked at was, did how much their emotion regulation improve across therapy? Did that tend to correlate with how much symptom change that they had? And we found that it did, in the sense that the girls who had the best symptom reduction also showed the most improvement in the ability to regulate their emotions. So this is suggesting, this is not conclusive in any way, but it's suggesting that maybe one of the mechanisms by which TF-CBT helps with PTSD symptoms is by improving the child's ability to regulate strong emotions. So that's at the behavioral level, and that's using just a self-report measure of the child's ability to regulate her emotions. We also want to look at the brain. So like I described, we had the cognitive reappraisal task, which is very similar to what you teach the child to do with cognitive restructuring. And in the scanner, there's three task conditions. So sometimes they just see the negative image and they're asked to just pay attention to their feelings while they look at the picture, don't change it. Sometimes they see the negative image and they're told to try to think about that image in a way that makes them feel better. So that's using those cognitive restructuring skills. Or they're just shown neutral images and they're told to pay attention to their feelings to the neutral images. So what I'm showing here is I'm showing the girls who responded very well, so they had the steep treatment slope, and the girls who didn't respond as well. And this is brain activity pre-treatment to post-treatment in both of those groups. So what we have here, this is the posterior insular cortex. And what we found was that how connected this region was with the amygdala changed from pre to post treatment only in the girls who responded best. So that's kind of complicated, so I'll say that again. The girls who responded best showed a change in how these two regions were connected. Specifically, the girls who responded well to therapy, after therapy, they could suppress the connectivity between those two regions. Whereas the girls who didn't respond as well, they were not able to do that. So if we look at the girls who responded well from pre to post treatment, they showed this suppression of this connectivity. So FC here is functional connectivity between this region and the right amygdala. So from pre to post treatment, their brains showed suppression of that connectivity when they're reappraising. So it's specific to when they're actually trying to feel better. When they're trying to feel better, they suppressed how much these two regions were connecting. The girls who didn't respond didn't show that suppression. So that was true for the functional connectivity between the right amygdala and the left insular cortex. Also true of the right amygdala's connection with the right insular cortex. And we see a very similar finding. That the girls who responded best after treatment were able to suppress the connectivity between those two regions when they're trying to feel better, and the girls who didn't respond as well were not able to do that. So this is pretty good evidence that that the benefit that TF-CBT is producing in regards to PTSD symptoms, in regards to emotion regulation, might be due to the brain's ability to suppress this connection. And that kind of makes sense if you think about what these regions do. So I already mentioned that the amygdala encodes salience processing. So it becomes active when there's something really important that we need to pay attention to. And the posterior insular cortex is involved in encoding autonomic changes. So when your heartbeat speeds up, or when you start sweating, or when your muscles tighten, or when you have an emotional reaction, this region becomes active. So to see that the connectivity between those two regions suppresses in girls who respond well makes a very good intuitive sense in the sense that their emotion, this is a marker of how much emotion they're experiencing. So they were neurally able to suppress that marker of emotion when they're trying to. So this is pretty good, like I said, this is pretty good evidence that the brain has gotten better at regulating emotions. And that might be how TF-CBT is producing those clinical outcomes. So that is a pretty interesting finding. Something else that we found that's interesting is that it's not so much the case that in our girls who didn't respond well, that they lacked brain changes, right? So based on the previous slide, you might think that TF-CBT needs to change certain regions, and if it doesn't change those that brain function, then the girl won't respond. What we also found is the opposite of that. So with some patterns of brain function, we only saw the change in the girls who didn't respond, right? So here what we're looking at is the connectivity between the dorsal medial prefrontal cortex and the amygdala. It got stronger after treatment in this negative reappraised condition versus the negative view condition, but only in the girls who didn't respond well. So we didn't see a change in that brain marker in those conditions in the girls who did respond well, right? So from before to after treatment, it's pretty much identical. But from before to after treatment in girls who didn't respond well, we see very, very big changes in how their brains were functioning during this task. So what this is suggesting is that in these girls, there's this competing brain response. And maybe the development of this brain response throughout TF-CBT is actually counterproductive. So we really need to figure out a little bit. What this suggests to me is that we need to figure out more, not just what's going on in the girls who do well, but what is going on in the girls who don't do well, and how can we maybe tweak TF-CBT to prevent these competing brain changes from happening. Okay, so like I mentioned, we had at the behavioral level, in terms of a clinical measure, we found that PTSD symptom reduction might be mediated by improvements in emotion regulation. And when we did a very similar analysis of brain function, we found that suppression of the amygdala-insula functional connectivity, we saw that in the girls who responded better. But we also saw that this heightening of connectivity between the amygdala and the dorsal medial prefrontal cortex is actually detrimental. So it's not, like I said, it's not just the case that certain changes are good, but it also seems that certain changes are detrimental or counterproductive. So if we look at kind of the overall implications of this, like we started out with, the problem that we have is that there is this variability in how well children respond to TF-CBT. That's the problem. We want it to work 100%. So this study was to start to examine what are some reasons for that variability. And at the symptom level, we found that how strong the symptoms, how severe the symptoms were at pre-treatment, just like in most clinical trials, predicted how well the child was going to respond. In addition to that, we also found that how well the adolescent discriminated danger from safety was a significant predictor of how well they were going to respond. So the girls who were at the brain level were able to differentiate danger from safety and show that amygdala response only for danger but not for safety. Those are the girls who did best in TF-CBT. And the girls who didn't do well showed that brain response to both the fearful and the neutral stimulus. And in looking at the mechanisms of how TF-CBT works, these data suggest that at least one mechanism through which TF-CBT might be helping is actually by helping the child learn to regulate emotions better, giving that child better tools to handle those strong emotions. And then that's at the behavioral level, and we found that that mapped on to specific changes in brain function. So for me, somebody who is also a clinician, in addition to doing research, the biggest take home for me is this point here, that the target of what you're trying to do in TF-CBT as a kind of an overall framework of what you're really targeting, what you're really helping that child with, is learning to regulate emotions. And that's a framework for the affect regulation modules, that's a framework for the cognitive restructuring modules, that's the framework for building the trauma narrative, that processing that trauma, identifying those distortions, all might be tools that are helping the child learn to regulate emotions, and kind of using that as an overall framework for what you're doing with the child. And obviously there's a lot of limitations to this study. This is the first study of its kind, so it was done on a smaller scale. We only had 25 girls actually finish therapy. It was only with girls, so we don't know the degree to which these results would generalize to boys. It's only 12 sessions. Like I mentioned, this is not how you would do therapy in your office. You're going to do it in a much more flexible way. But for the sake of doing research and making it comparable, like I said, we had to kind of limit it to 12 sessions. And we don't have long-term follow-up data. So ideally, we'd want to know how are these girls doing a year after therapy, 5 years after therapy. How does therapy maybe put their brain back on track for normal neurodevelopment? Those are all things that we'd like to know that we can't answer with this study. And then real quick before I take more questions, just mentioning that we're doing more research studies. So I'm biased, obviously, but I think the research that we're doing here is helpful in regards to learning how to treat this population better. And we're able to get these interesting results from the study I talked about today because you all helped with referrals to the study, and we're doing more research, and I would love to keep getting your help referring participants to our studies so we can keep learning how to help this population. We're doing more studies with adolescent girls, trying to understand how early life trauma changes brain function to increase risk, not just for PTSD, but increasing risk also for drug use disorders, increasing risk for being re-victimized in adulthood, and increasing risk for social problems, so problems with intimacy and trust. So we've got studies going on for each of these. And what we're looking for, again, like I said, are adolescent girls, age 11 to 17. We're looking for girls with or without histories of physical sexual assault. So we're looking for control adolescents in addition to our traumatized adolescents. And we're looking for adolescents with and without histories of drug use. So because it's an MRI study, there can be no internal medals, so girls with braces wouldn't be allowed to participate. The adolescent and their caregiver would both earn monetary compensation. So on average, the child's going to earn about $100, and the caregiver is going to earn about $40. And this is the contact information. If you wanted to give the information to a patient you're working with or family you're working with, they can call Jennifer to learn more about the study. So I appreciate the opportunity to tell you all about the study, and I will take some questions now if you have them.
Okay, thanks, Josh. That was a really informative presentation. One of the questions that came in, I think this was on one of your earlier slides, it said that they noticed that there was a substance use increase according to the post-tests.
Okay. Interesting, yeah. Let's see if I can go back to that. Oh, you got it. That was a lot faster than I could have done.
Out here. Let's see.
Okay. Oh, right there. Right here. Yeah, so that would be, I guess, one girl. So yeah, so an interesting thing about this definition is it's based on the last year, right? So nobody could lose this diagnosis. So the 12% was probably not going to change, and this 5% increase would be one girl who developed worse substance use symptoms during therapy. So that might have been, if this is abuse, it might have been, a night of binge drinking where she got caught for it or something. But yeah, that is definitely an increase, and attributable to one girl's symptoms getting, substance use symptoms getting worse.
Okay. Just trying to find mine. I know some other folks have written some questions, so get to. Okay. Another person's asked, what's the rationale for seeking only girls for these studies?
That is a very good question. So there's two reasons for it. So one reason is that we know that there's sex differences in brain function. So if we recruit both boys and girls, that introduces a lot of heterogeneity in the sample, and it makes it harder to find the differences in brain function that are due to therapy. You can do it, but you need a much bigger sample if you're going to use both boys and girls. So because this was a pilot study and we weren't going to get as many participants, we needed to pick either boys or girls in order to have more power, statistical power in the study. So the reason that we chose girls instead of boys is because we know that girls are actually at increased risk for developing PTSD after trauma. So if there's a greater clinical need, it's actually a greater clinical need in first understanding the response in girls. Not that boys are not important, but just that we had to pick one or the other, so we picked girls for that reason. That is a good question.
Thanks. Yeah, and just a reminder to go ahead and type in your questions. Now we do have another one. Do you think this is sort of the future for evidence-based practices, brain imaging? You want to speak anything to that?
Yeah, so I think that is a very interesting question. In an ideal world, I would actually hope that in standard clinical practice that brain imaging is not used. And the reason I say that is because this is a very, it is not a widespread technology. You know, if you have someone showing up in your office, you can't just give them a brain scan. It's expensive, in addition to not being easily accessible. So in a perfect world, what we would end up doing is that anything that we can identify at the brain level in our scanner, we might find a more easily accessible measure that you could use in the clinic. So in terms of standard clinical practice, I hope that brain imaging doesn't become more widely used because it's not very practical and it's very expensive. But I think that the place that brain imaging has is informing how treatment works. So I think that the future of treatment development and treatment testing is going to be integrating the standard clinical trial procedures where you're delivering a therapy and you're measuring clinical symptoms, and integrating that with also measuring changes in brain function, because that adds a lot of value into knowing how the treatment works, who it's going to work for, and developing ideas of maybe novel assessments you might do in the clinic. So for example, what we learned in this study is that discrimination between threat and safety might be a really good marker of who's going to get better. And there's probably a cheaper and easier way to measure threat safety discrimination without a scanner. And now we know to look for that, whereas before we didn't. So that's how I think brain imaging is going to be used, hopefully in the future, is by informing the treatment, but not necessarily in standard clinical practice.
Thanks. So yeah, feel free to, we have some time if you'd like to write in questions, please feel free to do that. I'm going to go ahead and just advance to the next slide. For those that are interested in getting a CU, just remember to, when you do email me, to tell me your first and last name, and if you watched as a group, just each person email me individually and tell me who signed in or who was the person you watched or what computer you watched on. And just as kind of a FYI heads up, our next month's webinar is going to be about children and cybercrimes, and will be presented by Will Jones, Assistant Attorney General. So he heads up that division and prosecutes crimes related to that. So that should be really interesting. So feel free to keep typing in questions. We do have some time to answer those. Okay, another question did come in. Okay, so someone, kind of back to the recruitment question. If I know of someone who is interested in participating in the study, do they have to come at a specific time, and where do they go?
Yeah, that's a good question. So they would come to to UAMS. We are in the Psychiatric Research Institute at UAMS, and we schedule appointments based on the participant availability. So a lot of the parents or caregiver and the adolescent, want to come in the afternoon or maybe late afternoon after school, and we can work something like that out with the participants. So if they call that number that was up on the screen for Jennifer, she can schedule them at a time that works for them.
I'm going to back out to that slide just for a few minutes so folks can copy that.
Oh, yeah. Good idea.
And this is a question about the study, Josh. Were the girls asked how long ago the trauma was experienced?
Yes, we got a pretty detailed history of their trauma exposure. So we got the ages at which different traumatic experiences happened, and how many times it happened, and who did it, where it happened, et cetera, et cetera.
Okay. Another question is there anything that we should change in light of this information at this time? I'm guessing that's referring to change anything in their TF-CBT practice is what I'm guessing the question's referring to.
Yeah, that's a good question. And based on this study, which is a pilot study, it's kind of more exploratory. I wouldn't change what you're doing based on this. Like I mentioned earlier, the take-home message for me is kind of a framework for thinking about what TF-CBT is doing. And the evidence from this study is suggesting that a good framework for that is that you're targeting emotion regulation. So this is maybe not going to change what you do in TF-CBT, but maybe changing a little bit how you think about it.
Okay, thanks. Let me take one or two more questions. So if you're writing something, we'll kind of pause for 30 or so seconds, and then we'll end today. And of course, if a question comes to your mind, you can feel free to email that to me, and I can forward that on. So just take a moment if you need to ask a question, do it this time. Okay, well, I'm not seeing any other new questions, so thanks everybody for joining. We hope that you can join us next month, and thanks to Dr. Josh Sisler for presenting today. It's always really great when we kind of recruit subjects, and now we have results and we can talk about it, so thanks for doing that, Josh. Appreciate it.
Yeah, thank you for the invitation.
I'll leave this slide up for a few minutes for folks to email me their CEU code.